Thank you so much for the introduction and also for having me. I would like to look at the treatment side of tinnitus a bit more, and that's because I'm also working with the Tinnitus Center here in Jena, where we treat patients with severe chronic tinnitus. And I would like to tie this in a bit with a few psychological and neurophysiological perspectives from my PhD project, which is still ongoing, of course, so you will see some preliminary results in the end there. So to start off, I would like to highlight one important point from the tinnitus definition. So, of course, as you all know, tinnitus is defined as a phantom sound, but importantly, tinnitus itself does not qualify as a disease or disorder. So it's a symptom, first of all. But it can be much more than that, because to many patients, it is not just any sound, but an aversive sound that probably gains its aversive character due to dysfunctional learning processes in the transition from acute to chronic tinnitus. And if that happens, we can then talk about tinnitus disorder when associated with emotional distress, cognitive dysfunction, etc. So tinnitus symptoms are often well compensated. We have 14% of the European population who report chronic tinnitus, but only 2% experience severely bothersome tinnitus, which is associated with considerable psychological distress. So interconnected cognitive and emotional processes seem to be central for the development, the maintenance, and also the treatment of tinnitus. The psychological or emotional reaction to chronic tinnitus is also referred to as tinnitus-related distress. This is used to measure tinnitus severity and mostly our primary outcome variable. In the Tinnitus Center in Jena, we mostly use the Tinnitus Questionnaire. It's a self-report instrument that differentiates between compensated and decompensated symptom levels. Compensated means that patients report low secondary symptoms. Their tinnitus can be bothersome at times under the experience of mental or physical strain, but most of the time patients feel fine. As opposed to the decompensated level, where patients really suffer from ongoing tinnitus annoyance and psychological distress, and this can go up to severe psychological decompensation, which also often includes suicidal ideation. What these differences show is the more pronounced the tinnitus distress, the more likely comorbidities are present. And an overview of the typical comorbidities can be seen here. You don't have to be able to read any of this. It just goes to show how vast those comorbidities really are. And amongst the most frequent comorbidities, we have major depression, anxiety, and somatoform disorders. And what we can see here already is kind of a bidirectionality. So tinnitus can, of course, trigger disorders like depression, but in turn, psychological disorders are also risk factors for the development of tinnitus and can intensify tinnitus-related distress. From an auditory point of view, tinnitus also co-occurs with hearing loss, of course, and also, for example, with hyperacusis, which is an oversensitivity to sound. So taken together, all of this can be very debilitating to patients, and this is also reflected by the socioeconomic cost due to tinnitus that is estimated to be up to 325 billion euros per year in the EU alone. So the next question would be, what can we do about this? And at the Tinnitus Center, as I said, we treat patients with severe chronic tinnitus using an interdisciplinary treatment regimen. That includes cognitive behavior therapy. We also use aspects of acceptance and commitment therapy. We work together with ENT doctors, physicians for physical and rehabilitation medicine, with physiotherapists, and also audiologists who fit our patients with hearing aids for sound enrichment and to counteract hearing loss. All of this is done in a group therapy format that's oriented towards topics that are important to tinnitus patients, such as attention, stress management, rumination, and also sleep disorders. And our treatment goal is always acceptance, which means we don't try to make tinnitus change or disappear from patients' lives, but we try and help patients to accept the tinnitus perception without actually changing it, and then actively regrow a fulfilling life with tinnitus. And this is what we then would consider treatment success. So how successful are we? Here you can see the change trajectories in tinnitus-related distress of patients who had been treated at the Tinnitus Center in Jena across different severity grades, and beginning with a preliminary screening appointment. Then we have the actual treatment phase between T1 and T2, and then we have several follow-up appointments, 2 weeks, 6 months, and 5 years post-treatment. And what we can see is a significant improvement due to therapy in all severity grades, with most patients transitioning from a decompensated to a compensated state. And then after that, we see stable long-term treatment effects up until 5 years later. But what we can also see is that we have very large variations in those later assessments, which probably emphasizes the high heterogeneity in tinnitus patients that we see time and time again. But it can also partly be explained through hyperacusis and subjective speech comprehension difficulties. So hyperacusis in itself is associated with increased tinnitus-related distress. The co-occurrence of both conditions increases over time, and this might be a key cause for complaints about tinnitus in the long run. Hyperacusis, together with speech comprehension difficulties, also might promote social isolation behaviors that are then closely correlated to depression, for example. But first of all, it also shows the importance to have audiologists on our team to address these hearing-related needs. I've already mentioned depression as a comorbidity in patients with tinnitus, but it also represents a crucial therapeutic target. So we have various studies that have shown the association between tinnitus and depression. I won't go into too much detail here to save some time, but tinnitus and depression are closely linked, this is safe to say, but the underlying mechanisms have been a long-standing question. So we were interested in the co-development of both conditions across treatment. So we analyzed 2 large data sets using a combined analysis with machine learning and latent growth curve modeling. And from a clinical perspective, we were able to show a bidirectional relationship between tinnitus distress and depression, meaning we see correlated change trajectories in both conditions over time, over treatment, that can partly but not entirely be explained by somatization and distress-related components. So we have a core depressive common symptomatology remaining that is common to both conditions. And this leads to the conclusion that addressing depressive symptoms enhances treatment response in tinnitus patients, but also vice versa. And this is not routinely done yet. We see many depressed patients who also report tinnitus, but never receive the tinnitus-related support they actually needed, even though it would improve their depressive symptoms. Now, lastly, switching gears a little bit, this view that tinnitus is not a purely auditory phenomenon is also very well supported by imaging studies. We see an involvement or increased connectivity among auditory and also non-auditory brain areas, including the limbic system and frontal regions. And in this 2019 study here, resting state MEG data were used to analyze connectivity differences between tinnitus patients and controls. And what they were able to show was that tinnitus patients show increased connectivity from right dorsal prefrontal to right medial temporal areas. And they also highlighted the active role of the dorsal medial prefrontal cortex in modulating the left parahippocampal area. So, and this is a very new part of the project I'm working on at the moment, is we also collected MEG data of patients who were treated at the tinnitus center. And so far, we see a similar pattern when comparing pre and post-treatment resting state data. So as I said, this is still preliminary. This is very new. I hope it stays significant when we look at the whole data set, but we are very excited about these results so far. Now, to conclude, I wanted to reiterate that when talking about tinnitus, it's of course a complex multifactorial phenomenon that we can treat effectively and sustainably in an interdisciplinary setting, also in a very short amount of time. And we see alterations in functional connectivity due to treatment. What we also see are highly variable pathways of disorder development, which is probably a testament to the heterogeneity that we see in the tinnitus patient group, but it also means we still need to work to further personalize treatment approaches, meaning a combined treatment of tinnitus and psychological disorders, while also including audiological interventions. And with that, I would like to thank you for your attention, and I'll be happy to answer any questions in the comments.